All right, the next item on our agenda is 1B, hear a presentation, discuss, and provide direction on the Mesa Fire and Medical Department's Community Care Response Initiative as it relates to a grant award. So this is great news. Congratulations on being successful in the grant. We're excited to hear how you're going to spend all that money.
That won't be hard, Giles. Let's see here. This thing doesn't go all the way. Can you get that to me? Let's see. This cord doesn't go.
This one works, right?
Yeah. Okay, thank you very much. Giles, members of the council, thank you so much for having us here today. And as you mentioned, this is a grant that we've been awarded. We were at council over a year ago asking for funding to apply for this grant. And thank you to the support of the city manager's office, the mayor and council, we were able to apply for it. Fortunately, we did receive the award. And you will see it on the October 6th agenda as an action item to approve the resolution to accept the award. So we're here to kind of tell you a little bit more about the details and just to review what we've talked about a year ago. And I have to say this is very, very important for all of us because I think the grant that we applied for here, we applied for $13.7 million, only received $12.5. We're still very happy with that. But I think we're the largest that we know of, the largest fire department in our regional partners with Superstition Medical and Queen Creek that have received this type of award for medical services through the federal government. So we know that all eyes will be on the city of Mesa. And we appreciate the support we've been getting so far. City manager's office has helped us incredibly, purchasing, ITD, the budget office, Sharon Skinner from grants. So we've received a lot of support through the city because it's really a group project. So we're very thankful for that because I think this is going to help in the success of getting these programs up and running. So to start with, the grant partners that we are working with is Mountain Vista Medical Center, and they are the ones that supply the PAs for our program, the PAs and nurse practitioners. We've had the program running for about 2 years before we even applied for the grant. So when we wrote for the grant, that was already in there for that we've been running this program for 2 years. And please excuse me, I forgot to mention the gentlemen that are with me, and I apologize. To my left is Dr. Gary Smith. He is our medical director for the fire department. Dr. Smith has been instrumental in really helping us to move forward with these innovative medical programs that haven't been done across the country. Deputy Chief Steve Ward. Steve is our program manager for the grant from the fire department. So Steve's going to help run all the activities that surround the grant. Yep. It'd be a fun job. and to my right is Tony Logidice. And Tony is actually our grant administrator. And Tony wrote the grant. So Tony's instrumental in making sure we follow the guidelines of the grant as we move forward. So pardon me for forgetting to introduce them in the very beginning. So our partners with the grant are Mountain Vista Medical Center, CPR Behavioral Health. CPR is the one that is the company that has provided our behavioral health folks that run the behavioral side of the grant, which we'll go into as we move forward. Superstition Fire and Medical Departments. They are also going to have a PA behavioral car in their city as well. And then AT Still University. We're going to use AT Still. Their PAs are riding with our program to kind of gather information, working as a PA. We're using their educational facility for training, things like that, and also for education that we're going to do to the communities. We're going to utilize AT Still for that as well. And then the town of Queen Creek. Queen Creek wants to have more of an observation role, but also as we move forward in the grant and respond on patient follow-ups and things like that, they are in agreement to go ahead and work with patients in that area as well. A little bit about the information. We were notified on July 8th that we were awarded the grant. That was about almost a year from the date that we applied for the grant. We received $12.5 million. The good thing is there's no cost match to this grant. It's a 3-year grant, and the first year is $4.5 million that we're going to spend, so it's divided in the second and third year about $4 million. The grant pays salaries, benefits for the key personnel and related equipment. So all of the PAs, all of our fire personnel that are going to be running on these cars and these units are going to be paid for by the grant. And also just some equipment some associated equipment that goes with the program. And then there's no further programmatic commitment required beyond the final reporting. So we're going to do quarterly reports. Right now we have a project manager that we report to weekly with CMS. We give updates to, we ask questions to. If we have changes or amendments to the grant, we will work through this project manager. And so they'll keep them up on what we're doing. So, but once the grant, we do our final reporting, there's no other requirements from the city. And there won't be any outstanding, one of the requirements per council when we apply for the grant is that we don't have outstanding costs after the 3 years. So we've worked it out that once this is done, we're going to hire contract employees through attrition, the company officers that are going to be on these units, through attrition, if for some reason we can't sustain this, through attrition, they will go back into, we will not have outstanding costs in personnel in that regard either. So we've worked those out as well. Now we're going to have Chief Ward go over the program goals that we're going through.
Good morning. Thank you. So Chief Camelli spoke about the award information. So I just want to expand a little bit this morning on the program goals for you, just briefly. So what we're really looking at here and what was presented in the grant was to look at more efficient ways of doing business and some innovative ways of doing business. And so, of course, when we talk about that, one of the things we talk about is costs. And as written in the grant, one of the things that we're going to do is what we call pseudo-billing. That's one of the ways we're going to look at cost savings. So the grant has provided us the ability to procure a service to do some this mock billing. And what our goal is to move the billing forward through the process, but we're not actually going to move money. So what we can actually do is see the difference between our new innovative ways of doing business versus what the traditional ways of doing business are. So our customers are not going to receive any bills. There will be no co-pays, but we will have the ability to see how that billing would have moved forward, and that way we can measure the difference in our way of doing business traditionally versus the way we're going to be doing business with the grant.
So, now, Chief,
yes.
The pool of money that we receive from the federal government is covering the cost of those things, and you're going to go through a mock billing process as if you were billing, and that would test the system. Is that basically what this amounts to?
Yeah, that's correct. So, of course, one of the big goals here is improved healthcare outcomes. So we're going to work with our partners, and we're going to really look at patient outcomes. That traditionally has always been very difficult to do. However, we have very strong partners on the professional side, and we have come up with ways for them to report that to us, and we're required to report that to CMS as far as our patient outcomes. And one thing I want to touch on, this is very data-driven. We're going to be doing some really robust data reporting to CMS. We have been, over the last 2 years, doing some pretty good data reporting internally to look at these programs, and we've done a really good job with efficiencies. But we're really going to expand that under this program and do some very robust data analysis and reporting to CMS. So overall, we're looking to improve the healthcare system efficiencies. And when we talk about overall system efficiencies, we're also talking about right here, as far as what City of Mesa does in our pre-hospital health care. We're part of the system. We're looking to show system-wide, including what we do here, efficiencies, which leads me to the next thing here on the bullet points. It says test sustainability. I'd like to take that a step further, and what we really want to do is prove sustainability over the next 3 years. And when I talk about proving sustainability, we're looking at fiscal sustainability and operational sustainability right here in the Mesa Fire and Medical Department and in the region. That's our goal there. And then, of course, continue improving service delivery. That really is the overall goal. The great thing about this is that our citizens and our customers are going to be able to experience these improved service models that we've been able to do on a small scale, but now we're going to really do them on a big scale, and we're going to be able to provide these services to many more of our citizens here in Mesa, and we believe it's going to be a great thing.
Great. I have a quick question. I assume part of the reason this was such a well-received application for a grant is because this is a really interesting idea where we say, look, we're going to prove to you, or we're going to test the financial sustainability of this program by actually doing a mock billing program, so that at the end of this we can show whether this is a good idea or not. So I assume it would be a violation of the grant criteria if we were to actually bill anyone's health insurance, correct? Even though but we're going to ask them the question, do you have health insurance? Yes. Can I get that number? Here's how. We do everything except push send to the insurance company. And the reason that we need to explain to the citizens that we're not actually trying to recover any of that money is because that would violate the terms of our grant, I assume.
Mayor, that is correct. We are not looking to recover any money. What we are trying to do is just show the movement of how that would look so that we can compare those costs. And we will be working with the payors to do that without actually moving them. So there will be no co-pays, there will be no bills sent to customers or anything like that.
And Mayor, to add to that, we are going through the RFP process for the billing service because that is included in the grant to cover that cost of a billing service. So when we do finish the RFP process or as we're going through it, we'll advise them that this is how the approach is with this billing service that we're going to obtain.
And then obviously at the end of the program, we'll be able to see, the council will be able to see from a financial standpoint if we just turn the key on the system and start sending out bills when the federal money runs out, we'll either break even or not, right? Okay.
That's correct. Any other questions? Okay, next we'll have Dr. Gary Smith go over the programs that we're doing with the grant.
Yeah, thank you for allowing us to be here. This is fantastic. As we have taken a look at this community care initiative, it's gone back a couple of years, and so we've actually have a proof of concept. The proof of concept has been over the past 2, and we have demonstrated the effectiveness of this model within the city of Mesa, and it's very positive to see. It's morphed a little bit since its early inception, and it will continue to change over time. What we're looking at currently is these community care units that are going to be operating every day of the week. And so holidays, weekends, nights, it doesn't matter. We'll have units that will be in service. They'll be staffed with a captain paramedic that is a suppression officer, and we'll also have an advanced practice provider. That advanced practice provider will either be a nurse practitioner or a physician assistant. And they'll be the ones that are under contract through Mountain Vista Medical Center. And they'll be the ones providing a majority of that service. Most of this will be on low acuity patients. On occasion, it may be on an emergent patient, because if there are the units that are very occupied and busy throughout the city during a busy time, these individuals may have to respond with lights and siren, but that would be the very, very minority of this situation. The other that we see is the community care special units that will be manned with behavioral health specialists along with a suppression captain paramedic so that we can help evaluate those patients as well. We've identified what those peak times have been over the last approximately year and a half that we've had mental health services being provided. We are actually providing that service at the point of call and then managing the person whether they're or being taken to a more appropriate facility outside of an emergency department where it's very cost prohibitive to continue with the healthcare system currently. And so we take those patients specifically to behavioral health facilities and they receive them directly and primarily. Go ahead.
What you're bringing up now is that we would be able to be transporting these patients to alternate facilities, not to hospitals. So that begs the question, because the state of Arizona Department of Health Services regulates transportation. Where are we in that process with the state of Arizona about taking patients to alternate facilities?
Thank you. A couple of items with respect to that. One is the police department has the ability to transport a patient wherever a patient's needed to be taken.
The state doesn't regulate that.
That is correct. Nor do they regulate the city as a whole in taking a person to an alternative destination. For example, we can do that with a city-provided vehicle without billing for that service. Now, the only time where it is that the Department of Health Services is going to get engaged with that is if we send a bill for that transportation. When we are not sending a bill for that, we are not jeopardizing any of the statutes at the level of the Department of Health Services. So we're in a very safe zone.
Yeah, though I would say that watching this, the Department of Health Services folks are probably squirming a little bit on that one.
We'll continue to watch.
Their interpretation. Oh, I have no problem making anybody squirm. Don't get me wrong. I'm a little concerned because their interpretations sometimes differ than the rest of us.
Councilmember Summers and members of the council, we have met with DHS and we gave them the full presentation. They're very aware of what we're doing. So they haven't mentioned anything to this point, but they're aware that we're doing this program.
They're doing one of those, we're keeping an eye on you type of thing. All right. I think at some point a CON for this kind of thing would cover everything. It also allows us to bill for that service in the future once this this program is done, and we look, because you mentioned on the previous slide or two that we were looking at the sustainability, financial sustainability, test sustainability of the program, and so having that CON for transportation to alternate facilities, I think, is an important aspect of this program.
Thank you. I think this is a great program. I just want to understand operationally how this is going to happen. So we have a trained community care specialist that will be in the vehicle, and then they decide to pick up somebody, then make the assessment or ascertain whether this person is exhibiting any mental health issues, then call the nurse at a facility and say, we have this patient that's exhibiting some signs of mental health issues, and then you would actually transport that person to that facility. Is that correct?
Yes, sir. That's correct.
Okay.
The next item is looking at nurse triage in the communication center. And the communication center, when a person calls 911, there's a process that takes place with a call taker. That call taker will go through various questioning, as they normally would with any 911 caller. And once it's determined that it's going to be a lower acuity call, that'll transition that away from the 911 operator directly over to a nurse who has been trained in triage. For example, if you were to call your physician's office after hours, more than likely you would receive a nurse triage that would be asking you certain questions prior to even receiving any kind of advice or what you need to accomplish. And so we'll be doing the same thing, allowing them to have the most appropriate service being dispatched to that particular caller so that we can provide the greatest service that is necessary. That nurse triage individual would have access to a 4-person ALS company, all the way down to something of a paramedic level response that is of a low acuity nature, and having the advanced practice providers and mental health specialists that would be going out there. And sometimes we'll even take a look at down the road, we're not there yet, whether or not we even need to have a response. Because a person, all they may need to do is take a couple of Tylenol and call their physician's office in the morning. And that's really what needed to be done. We send out 4-person companies today on many of those kinds of calls. Many times they're after hours and many times after 10 p.m. And so we want to try to minimize that type of traffic when necessary. The next item that you'll see is follow-up care. That's patients that have been hospitalized and are discharged back home. So they don't go to a skilled nursing facility, but they go directly home, or from a skilled nursing facility to home, that we can actually go out and evaluate those patients. It's gap coverage. We're not looking to get into the home health care business. Until home health care can actually get out there to start caring for those patients long term, we will actually supply some services that would be there. And this, to be honest with you, is outside the grant. Okay? You need to understand that piece. And so it is a billable service. It's something that can be compensated, whether it's based on a capitated rate or whether it's on a fee-for-service type, or whether we look at it in another mechanism to have coverage, cost coverage, or to allow us to continue those services. We provide a very robust immunization program throughout the city of Mesa. It's a wonderful service that's accessed through, we have a partnership that we have with Mesa Public Schools, as well as many other entities that are out there, and we are very aggressive towards helping immunize the public. Herd immunity is what it's all about. The more people that are immunized, the fewer incidents that we'll have of infectious diseases. And so it's important that we continue to immunize those individuals. We'll have a mobile service-based home inspections. And so in other words, when we go out to a person's home, if it is on a follow-up care or at any other time that we are requested, we can actually do a home safety inspection, looking for fall risks, taking a look for fire issues that may be within the home, and try to minimize the number of incidents that we would be responding on based upon individuals specifically with ground level falls, which is a big number of our calls. And then we also are moving towards centralized medical direction. To describe that for a moment, what currently occurs is when a paramedic has a question that's on a scene caring for a patient, they call an emergency department. When they call that emergency department, oftentimes that physician that they would like to speak with is engaged in a procedure or an evaluation of a patient, and there's a nurse intermediary that takes that call, relays information to a physician, and then back to the paramedic. We believe that's very inefficient, and it doesn't provide the appropriate information from the physician back to the paramedic and to all services. Hence, we'll run this through the communication center There'll be physicians who are in a non-clinical role that will be taking that call 24/7 for all of the programs that we'll be involved in, from ALS care all the way to the low acuity and the mental health patients, so they can provide good advice to those caregivers that we have on scene. Any questions?
Yes, thank you, Doctor. This is obviously, the more I learn, the more impressed I am with what you're doing. Of these bullet points, is the only thing that's beyond the scope of the grant the follow-up care?
That's correct.
So, for example, the cost of immunizations, all of these other things are included in the funding. And so it's just an interesting idea. We roll up on one of these calls, we pull out our syringes at the end of the call and give everybody an immunization. We say, do you mind if we look around your house, and we point out some issues with the home, particularly say there's an elderly person with issues, and we can maybe address some of those in the home.
Mm-hmm. Correct.
And then we can come back the next day for the follow-up care and say, oh, by the way, we can actually bill your insurance for this call. And is our plan to actually bill for that portion of this service, or are we still just doing it for informational purposes only?
We've had discussion with various individuals with respect to that, and I don't believe we're not sitting in that seat just yet. Mm. But eventually that will be services that will be provided. There are ICD-9 codes, eventually ICD-10 codes that will be available for that, for billing on those kinds of services. Some of these CPT codes, which are a little different with respect on the billing side, the CPT codes need to be identified, and that's a portion of what we're going to be proving through this grant, is identification with the Center for Medicare and Medicaid Services to identify an actual code or a number that allows us to bill for specific services or care or treatment that's being provided on scene.
Very interesting. Thank you. Any other questions, Council?
We have one more slide.
Yes,
Thank
Chief.
you. And Mayor Giles and members of the council, just to add to the follow-up care, another thing we're doing with that is we have loyalty customers that we go on many times. What we're trying to do with these is the follow-up on them to prevent them from going back into the emergency room. So that also is what Dr. Smith was referring to on just preventing them from returning, having return phone calls into the 911 system.
Going in and be able to do something about the root cause of why they're loyalty customers.
Absolutely.
Right? Okay.
Absolutely.
Yeah.
So that was part of the follow-up plan as well. And now Tony is going to go over the cooperative agreements and the details of how we're going to abide by the grant.
Morning, Mayor and Council. We've used the term up to this point, grant. I want to change it up a little bit and really call it for what it truly is, which it's a cooperative agreement. Typically with your grants, the grantor gives you the money, you purchase your equipment or you run your program, you come back to them and you give them a follow-up report. In a cooperative agreement, we're going to have a lot of oversight from the grantor, from the Centers of Medicare and Medicaid. They are our partner in this endeavor. They want this to succeed as much as we do. So that's pretty much what it is. It's a cooperative agreement with them. With regard to that, our roles and responsibility for this is, first and foremost, is data collection and sharing. We're going to be collecting a lot of data, a lot of variables, not only us, but our partners. We're going to be aggregating this data and reporting on it, both for the grant and anything else that comes up in the future that we might want to try to explain. We're responsible for financial reporting and administration. This is not new to the grant world. Any type of federal grant where you expend monies, there's a quarterly and a semi-annual and an annual type reporting, so we'll be doing that as well. Programmatic reporting. We have a grants management from the Centers of Medicare and Medicare Services that we'll be working with for programmatic reporting. This will be done quarterly and semi-annually to them. Programmatic milestones, we'll be working again with our grants management specialists to meet our milestones and trying to get our program up and running by certain dates. Right now we're looking about December to start putting these units on the road, so the model will begin then. We're responsible for operations, as we discussed earlier, what those operations were, and contract compliance to make sure that we are in compliant with the notice of award or the agreement, but not only that, but our subrecipients to make sure they're compliant with the award, and our partners are considered subrecipients. Again, we were assigned a project officer. We've been meeting with them up to this point about weekly, bi-weekly, and of course, as that continues and the program gets started, probably on a monthly basis. They also may come for site visits throughout the grant, come to Mesa and see what we're doing firsthand. And of course, we have the responsibility to continue to work with our partners and build those relationships as it develops over the next 3 years.
Thank you. Great presentation. This is really congratulations to all of us for your success in getting this award. Our community is going to be greatly served as a result of this. So congratulations to you and to everyone that will benefit from this.
Thank you.
Good presentation.
Thank you. Thank you for having us.